I think the other key point is that over the last 10 years, when we realized or have more awareness of the mimic, once you take away the mimics, pediatric MS behave very similarly, or is the same disease really as adult MS, and in a way that age cutoff of 18 is totally arbitrary.
We think that probably efficacy is not needed anymore. I think, but still we need some clinical trials, but probably only one arm, and very long-term safety will be very important because still these children are in a growing period.
And I think that's something that we need to be aware of, because actually having the disease for 10 years and you're only 25, 20 years disease at 35, so you can imagine the impact on quality of life, employment, education, etc. Hi, I'm Yael Hacohen. I'm a paediatric neurologist from Great Ormond Hospital in London.
Hi, I'm Thaís Armangué. I'm a pediatric neurologist from Barcelona and I work in Sant Joan de Déu Children's Hospital and EDVAPS.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. Receiving a diagnosis of multiple sclerosis at any age can be overwhelming, but it can be particularly difficult when the disease impacts on children and adolescents. While paediatric onset multiple sclerosis is relatively rare, it presents a number of unique challenges that must be overcome. There are extensive ongoing research efforts around the world to try to better understand the disease mechanisms of paediatric MS, determine the similarities and differences that exist with adult onset MS, and make evidence-based decisions on the best treatment approaches for people living with MS under the age of 18. My guests in this episode, Yael and Thaís, are experts in the area of paediatric MS. Yael, Thaís, thanks for joining me.
Thank you.
Thank you for inviting us.
So I guess as a starting point for this, I mentioned in the introduction that paediatric onset MS is relatively rare, but what are our latest updates on the incidence prevalence of this globally, and are those rates changing at all?
I have to say we don't actually know the exact numbers, but there's always a question about the prevalence and incidence changing. Simultaneously, one has to consider the fact that there's increased recognition, and some of it may not just be because of pediatric neurologists are more aware of it. It may just be because it's easier to get an MRI scan when people have or children having symptoms. The second thing to consider is that there's been obviously a change in the diagnostic criteria over the years that would have affected how quickly we diagnose children. So perhaps even just being aware of children getting MS, getting their diagnostic criteria validated for children has helped pediatric neurologists internationally to diagnose MS in that age group. And I think finally, and Thaís can talk a bit more about it, both of us have done a lot of work on mimics of MS in children, in particular MOGAD and relapsing MOGAD. So in some way, one could even say that the incidence is going down, because we know that 30% of children previously being diagnosed as pediatric MS in fact had MOGAD and not MS.
Yes, exactly. The mimics are more important in this pediatric population because a lot of the frequency of MOGAD is higher than MS. The prevalence and incidence, as Yael say, it's not known, but it's thought that maybe 5 or 10% of people with MS will have the onset before the 18-year-old, no?
Yeah, I mean, I'm always a bit surprised by this fact, because at least looking at the UK, if you think that people say, 5% are pediatric. So it's the question about incidence and prevalence. And actually, in fact, in a country like the UK, we probably only have about 200 patients with pediatric MS at the moment. Yeah, we see them, they get diagnosed at the age of 15. So most of the time, they're only with us for a few years before they move across to the adult services. But I mean, I think we both wrote, many grant applications, and people go, if it's 5% of all MS, how come you have so few patients? So it's just the terminology of incidence and prevalence. And I think that data on the 5% went from adults with MS and asked them, how many of you had symptoms before the age of 18. So there's also a referral bias, I guess, answering this question of when do you feel like you first had some symptoms versus when was the first time, you were actually diagnosed or had an MS clinical attack.
And I guess moving from that now, obviously, as I said, extensive research efforts going into this area. What does the latest research tell us? Are there any differences that exist in paediatric onset MS to adult onset MS? What do we know about that?
I think that one of the most important differences is that at the pediatric age, the disease is more active and very inflammatory. And these kids really, in fact, has been delayed the treatment, but they need higher efficacy treatments because they are really very inflammatory. Another difference is the mimics, because it is very relevant because a lot of other inflammatory diseases, but also genetic diseases, can have the onset at these ages, and it's important. But what is the risk factors and genetic factors, and it has been shown to be very similar to adults. And I think the pediatric population, it's a great opportunity to study these factors at an age that there are less confounders than in the adult age.
Yeah, and I think the other key point is that over the last 10 years, when we realized or have more awareness of the mimic, once you take away the mimics, pediatric MS behave very similarly, or is the same disease really as adult MS, and in a way that age cutoff of 18 is totally arbitrary. And I think conceptually one needs to look at both inflammation and neurodegeneration changing with age. You do not, late onset MS is not different than adult onset MS. So across the lifespan, inflammation, and we know from other diseases, is more in the young and get less and less with age. And by contrast, neurodegeneration, at some point, age take more of an account. And when you're younger, there may be a protective window. So what we see maybe in the very young patients is that you get more repair. And, we know that although they have more attacks, the attack recovery is better, which is sometimes a bit misleading when you offer, strong, high efficacy treatment to teenagers with EDSS of 0 when they have no symptoms, and they go, I don't want to come to the hospital to have all this treatment when I'm feeling well. So I think this is stuff that we get more into trouble. But I don't think a 20-year-old would necessarily behave that differently than a 15-year-old. So it's from that point of view, I think more and more recognizing these concepts, not only for clinical practice, but also for accessibility to medication, etc.
And it's important one concept that say that they have more repair, and sometimes we don't see residual symptoms after an attack, but it's important to keep in mind that these children, for historical studies, have shown that they have a more slowly acquirement of this capacity. Maybe it takes longer, but they reach, if we don't treat aggressively, to very early ages. So it is not a benign disease. No, they repair well, but if you don't think in the future, they can be very impaired in future.
Yeah, if anything, it's a more aggressive disease, like most adult onset disease. If you look at the pediatric onset, that would be the more aggressive, starting early. And I think that's something that we need to be aware of, because actually having the disease for 10 years and you're only 25, 20 years disease at 35. So you can imagine the impact on quality of life, employment, education, etc. Which perhaps if somebody get diagnosed at 40, it's less of an issue what's going to happen to them. And I think the other thing, again, talking about medication, is that we also need to be mindful of how many medication one can be on. So I think we're in a bit of a luckier position at the moment that we actually have better medication than we had 5-10 years ago. But, there's a lot of things that, when you do start or get diagnosed with MS as a teenager, then you want to, I guess the way we engage probably with our patient is we're a bit more pediatric mindful than the adult onset disease, and the engagement with them and making sure that they take the medication, and compliance are other issues that we need to take into consideration.
Yeah. I mean, I think there's a lot of really interesting stuff in what you've both just been talking about there, because there are some really unique opportunities in terms of thinking about pediatric MS, and it opens up windows, and we talk about the repair mechanisms and things like that. We've seen some data around cognition in children with pediatric MS, and how the cognition, at least through school and educational attainment, doesn't seem to be impacted. But I know one of the things that was talked about is long-term, and when we're looking at disease duration, as you say, going across a longer time period than we would otherwise expect in adult onset MS, we don't know what that trajectory looks like down the track. I don't know if you've got comments around that in terms of what we need to be looking at, what data is shown. Be interested, thoughts? Cognition-wise, or just in general with symptoms?
I mean, it's very difficult to know how much the historical studies on pediatric MS that not only, as we mentioned earlier, included MOGAD patients that do present in a younger and have a higher risk of cognitive impairment, my feeling is, to compare to MS, but also historically the cohorts were not optimally treated. So even if you look at studies like the Paradigm study that came out in 2018 comparing interferon versus fingolimod is a drug that we generally consider as a high efficacy drug, the patient still continued to have new brain lesions and still continued to have brain atrophy, despite being on a drug that we consider high efficacy drug. So I think there's some interesting, at least personal experience in other centers of we be definitely getting a better disease control on the anti-CD20 medications. And most of my patients go on these medications, and I no longer have relapse clinics. So we see really in clinical practice. Brenda Banwell mentioned on Tuesday also, so she doesn't have relapse clinics anymore because we are now. So we used to deal with a population that even on treatment would have like 1 or 2 relapses a year. So now they stop relapsing. So it'd be interesting to see if the cognitive impairment that was in some way higher in pediatrics was directly driven by the inflammation, because if you get cognitive impairment at 35, it shouldn't be age related, or if this is really if you stop the inflammation, you would not get any cognitive symptoms. And furthermore, if you actually get no evidence of disease, which I think is a bit different, because I think if you have a disease that you've managed to reduce the T2 lesion, or if you it would give you some brain fog and you'll get some other symptoms that sometimes are difficult to delineate what's if you're not feeling well and you're not going to school and your mood is bad and you're not performing, is that truly because you have some cognitive impairment, or is that you're just not performing very well in cognitive tasks? And I think that's very difficult to find out. So it'd be interesting to see if this kind of cohort of patients that are much better treated would do much better cognitively. And at least from the last couple of years, I mean, my patients go to university, they go to law school and med school and get whatever they wanted to apply to. So I feel like they're definitely doing better at this stage.
Yes, I totally agree that now that are better treated, really the landscape is changing a lot, and there is a lot of more hope. And when you tell the parents, because when you say the diagnosis always is very hard, and you try to say that during the latest years, the treatments is allowing to better control of the disease. At least we don't see relapses anymore. The chances of having new lesions is very low. We cannot assure what happened in 30 years, because also 30 years of treatment will be a lot of time, and we don't know if we will be able to keep all these children for all their lives in immunosuppressants. But there is a lot of hope. Still, unfortunately, there is a subgroup of children, I think, that when they have the onset already have a high number.
Lesions.
Yes, a number of lesions already are impaired, and these patients also have already cognitive problems. Sometimes also it depends of the cognitive reserve, and it's important not to forget that some patients still have some problems, and they need some help, in
extra support. Yeah.
I mean, I'm keen to progress to talking about the treatment landscape, because the treatment obviously has come up a bit here, and I think the treatment landscape for paediatric onset MS differs around the globe a little bit as well. But where are we at currently with treatments that are available for children and adolescents with MS? And one of the things that was talked about extensively at ECTRIMS 2024 was around clinical trials for new treatments for paediatric MS. And if we're saying that really it's the same disease as adult onset, do we need efficacy trials, or should we just be focusing on safety? Interested to hear your thoughts on that.
We both have been agreeing on it for a long time. Thaís, do you want to?
Yes, we really think that like in some epilepsy, other diseases, that there are some diseases that there are more doubts if the mechanisms are the same, and then the efficacy will be the same. But we think that once you exclude MOGAD, when you exclude other mimics, the disease is very similar, and it has been shown in the latest studies and the clinical trials that have been done. And we think that probably efficacy is not needed anymore. I think that still we need some clinical trials, but probably only one arm, and very long-term safety will be very important, because still these children are in a growing period, and we maybe don't know all the effects that these drugs can do in this growing period. And I think that all the efforts and economic efforts of the industry, and maybe should be in the safety profile of these patients. Because nowadays we have a lot of thousands of children that are using these medications, but off label, and then the control is much less, no? And they are receiving the treatment, fortunately, most of them, because we cannot stop giving them the medications. But probably the control is less than if this will be in control trials.
You know, the evidence of the RCTs, I mean, they're quite demanding, particularly to children that, you know, have to go to school and have exams, and it's many hospital visits. And if you look at some of these studies, there's been a very high dropout rate in a disease that is anyway pretty rare and requires a multi-center, multinational site opening to even just reach recruitment over, you know, a number of years. So that's been very challenging. But what we've been doing in as part of Professor Ciccarelli, recent NIHR-funded study in UCL, is that we have a pediatric arm, and we actually have now recruited 120 children into that arm. So it's a clinical trial when we acquire generally clinical data, plus additionally brain volumes that we do additionally as a research and neurofilament and genetic analysis. So it's all been done as part of their clinical care. We have most of our, you know, we have a very high agreement to the study. Over 90% of our patients wanted to be part of this study. And, you know, the aim for this is really to not only just look at the first 2 years looking at efficacy, but also to try to follow them for a longer time to look at side effects. And in some way, I do feel that these type of studies, you know, one can maybe take it, you know, look example from the oncology models. In a sense, every child that starts, you know, chemotherapy go on this like global international database. And I, you know, for many years wonder if that's what we need to do. We need to capture this at any given point. I can tell my patient, okay, there's been 722 patients on this medication in the world. Of these, X amount responded and Y amount had side effects. And the more data we have, the more information we'll be able to give to our patients. So I find that, you know, recruiting 200 patients to a 2-arm study over 2 years doesn't give you all the information that perhaps you want to know.
Yes, I think it's very important and to collect this data in a prospective way, no? Because
live in a way, to constantly add
like
to that.
Registers, but not retrospective, no? Because if you use retrospective data, real world data in retrospective way, you are always missing some data, no? And some analyses are not performed everywhere in the same time or in the same manner.
Sometimes the messiness of that retrospective data, if you look at a multi-center, they do things a bit differently. And, you know, we've had some nice results on this for the MOG treatment, that we actually utilize the fact that different centers in Europe use different medication in different time to actually show which one works better. If all of us would have done everything the same, we wouldn't have been able to figure out these differences and what works better than not. So sometimes there is, I think, a place to retrospective data analysis. I think not instead of clinical trial, whether they're pharma or non-pharma sponsored. But I think
exploratory, no?
I think exploratory, you can get very quickly information on many patients to answer some key question if you're aware of the limitation of your data.
I like to throw one impossible question into every podcast, and I'm going to guess this is not an easy one to answer. How optimistic are you both around the fact that regulatory bodies will follow basically what is now consensus around this? Do you think we will see regulatory bodies shift their mindset towards going, we don't need efficacy? Do you think that's a change we will see, or do you think that they will continue to push for having these large phase 3 efficacy trials?
I hope that they'll start including pediatrics within, or at least post-pubertal pediatric patients within the adult trial. So then the medication will be, you know, licensed to at least post-pubertally. And I think the prepubertal group is anyway a group that is so rare, and their pretest probabilities of the mimics is higher. In some way, it's probably better that all of us will work a bit harder to get the right treatment for that group. But I think post-pubertally, their adult size, you know, we should, so that's kind of the way around it. I hope that would happen in the future. But
I think it's changing, because a few years ago they asked for placebo trials, and now we are gone of that. And also in some other diseases like epilepsy, in some syndromes that are very infantile, they require efficacy, and some syndromes that are not, they are more flexible. And I think it has to change. Personally, the thing that adding teenagers to adult trials, I don't think, okay, it's better than not have the approbation, but I think that at the beginning of this, when these trials are starting, maybe you are so sure about the efficacy or safety, and maybe it's not the better moment to try to test the children, no? Mm-hmm. Because if you have another option, if you don't have any option, okay, but if you have other efficacy treatments, I think it's not the best moment to try in children. Mm-hmm. But I think that this safety trials, it's very important to push also for the regulators, no? Because at the end you have a lot of children without any kind of control receiving these medications, no? And it is what is real life.
And I worry about what's going to happen in 10 years, not what's going to happen in 2. So.
Yeah, true.
But I think will change, but slowly.
Mm-hmm. So thinking further ahead, what are the next major questions that we need to answer in terms of paediatric onset MS, and what research avenues are you particularly excited about? If you think ahead to ECTRIMS 2025 in Barcelona, what topics will you be really interested to see data presented on?
I think the treatment de-escalation, whether it's extended interval to some of these anti-CD20 or even discontinuation in a proportion of groups, would be very interesting to look at. And in fact, ECTRIMS did a workshop on this a year ago, and similarly measuring the treatment response on treatment and off treatment that is a bit more difficult in pediatrics, where in some way the brain volume should be going up, the skill should be increasing, so it's a moving target. So I think measuring the treatment response, and even if we consider extending the interval to every 9 months or every year in some of these infusion, how do we know that the disease is not coming back before we see the relapses? Mm-hmm.
Yes, I think safety data also is becoming more large, no? Yeah. And I think it will be interesting because every time we have more experience with these drugs, safety data, also the new criteria will be applied for sure in children.
Yeah, we'll have to do a few.
I don't think we were missing a lot of patients because really children are so inflammatory that with the previous criteria you would take most of them except for the radiology isolated syndrome, that it's true that these patients needed to be treated, and it's very important to keep in the criteria, no? But probably we will see how this change with these mimics, the new criteria, if it is a problem.
Would not be a problem at all in children because they have so many lesions at onset. I think there may be an issue with sensitivity.
Exactly.
Specificity.
Exactly.
Because
I would like to see
mimics,
how work this for the specificity in children, with a lot of mimics. I think it will be very interesting.
Very interesting, yeah.
Well, look, it's a really interesting area. I want to thank you both for sharing all of your insights with us today on what's a really important topic. Thank you so much for sharing your expertise.
Thank you very much for the invitation.
And thank everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MSTranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with 2 key partners, MSTranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2024-25 ECTRIMS podcast series is supported by educational grants from Alexion AstraZeneca Rare Disease and other educational grant providers. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook and YouTube.